Infliximab fits into what we call our armory of medication. We have our non-steroidals which manage pain and help with stiffness, but don't actually change the course of your disease. We've got painkillers which really only work on pain and once again have no evidence in changing the course of your disease. But disease-modifying drugs and biologics do really have evidence that they change the course of the disease, making you less from developing further erosions and damages associated to your joints and less, therefore, disability later on in life. And then, of course, we've got the steroids that we can use to help should we run into problems. And the pattern of how we manage people, we definitely want to catch people early on in their treatment and their disease because we want to prevent any further damage and erosions. But at any time through your life living with these diseases, you should have flares that don't settle down or start to run into problems with. Once again, we want to capture you quite quickly and actually be able to get you back on the right course of treatment. And Infliximab was one of the first ones we've had, but since you probably went on then, there's been a whole host of new medications that we have available for us. And every time, that's why we closely monitor people, so if we think that they're losing benefit from the treatment, we can look and see if we need to switch their treatment. So disease-modifying drugs are then categorised kind of into three groups. So we've got our conventional disease-modifying drugs such as methotrexate, sulfasalazine, hydroxychloroquine. We've got the biologics, which Infliximab is part of. And then we've got the new JAKs, these inhibitors that work in a slightly different way. Conventional DMARDs are normally tablets, although there are some that we can give in an injection format. Biologics are all injectable, or they are either injectable through infusions or through self-injections. But these new JAKs have gone back. Because they're a small molecule, they can be given back as tablets, and they've got some really good evidence as well. Infliximab, there are two products that we use in Portsmouth. Remicade Infliximab was the one we were originally using before they lost its patents, and therefore we've now moved over to Inflectra. And I'll talk about biosimilars towards the end of the talk. But actually, the drug itself does exactly the same thing. There's no changes in dosage and the same frequency of infusions. It has a license for us in rheumatoid arthritis, psoriatic arthritis. It has a license in ankylosing spondylitis, although we don't use it so much in that group. And it also has a license in juvenile idiopathic arthritis as well. And what we know is, from the advent of the biologics, actually, there's a whole soup or a mixture of cells that are inflammatory that may cause damage to joints. And TNF-alpha, for which Infliximab works on, is just one component of it. What we now know, though, is not only that TNF is a key factor of inflammation, there are other cells, and why these new drugs work on different cells. So if Infliximab stops working for you, there is always an opportunity to switch to something else that may give you better control. The dose of Infliximab for rheumatoid arthritis is normally 3 milligrams per kilogram, and then for ankylosing spondylitis and psoriatic arthritis, it can go up to a 5 milligram dose. Some of the inflammatory bowel disease, which we see in the rheumatology department, they can also go up to 10 milligrams per kilogram. But in our groups, we can only use those two doses. And we have a loading dose regime, so you start the treatment and you have more frequent infusions in the first 8 weeks. And then once you're established on treatment, then you go to what we call the maintenance dose thereafter. And the aim is always to what we call treat to target, is to get the disease in as low a remission as we can to prevent damage to the joints and prevent disability. And what we learned from this treat to target approach is really we learned from some of the stuff from diabetes, that if you don't control diabetes well, then the quality of life and complications associated to diabetes become quite an impact on the individual. And then we all know we learned the same thing from high blood pressure. So if we know that our target is to try and get patients into low disease remission, then we can prevent other complications associated to the disease. So that's why you're on this ongoing active monitoring. So we are closely monitoring you through your blood tests and also what you tell us to see whether we've got you into remission or into low disease activity. If we've got you into remission, there is some evidence that we could either reduce the dose of Infliximab, or we could reduce the frequency of the drug to actually keep you well, but actually not over-suppressing your immune system. And we have a project called Biologics Optimization. So every time you see your doctor or nurse specialist, if they think your disease is so well controlled that we could do that, we would be offering you that as an option. And of course, this is what we're aiming. This is early disease where there's no damage to the joint. This is where you start to get some swelling of the joint. Here you can see the outlines of the joint. And then some early signs of joint space narrowing, which is associated to the inflammatory process. But this is the biggest thing in rheumatoid arthritis. What happens is you get these little erosions that occur, and then what happens with those is they then cause disalignment of the joints, which cause hand function problems and things like that. And the whole idea is to diminish that. Originally, the thought was that we would see these drugs doing some repair of the bone, but actually that hasn't been borne out in clinical trials. There is some studies say you get minimum bone healing, but I would say that once you've got to this point where you've got a nasty big erosion, you'll never repair that. That will be there for the rest of your life. But we don't want it to progress further, and that's why we put you on these treatments. Infliximab has a half-life in your body, so between 8 and 10 days is the most active in the body. Thereafter, your body starts to automatically get rid of it because it is a foreign protein to the body. And that's why you have to have the infusions every 8 weeks, because as soon as you've completely depleted, then there's a potential that your disease will come back. So that's why we treat you every 8 weeks once established on treatment. Infliximab is not licensed to be used in combination with other biologics and JAKs, but it does have a license in combination with other disease-modifying drugs such as methotrexate and sulfasalazine. And the evidence would also suggest that patients who are on in combination with those treatments do better because you don't build up the immune response to the drug, which means you don't get rid of the drug too quickly from the body, and therefore it does its job. And that's why you still see patients on methotrexate or sulfasalazine. We do want you to tell us if you're taking any over-the-counter herbal medication. We are finding that more people are looking to herbal medication or over-the-counter medications as a way of self-managing their disease. And we want you just to be honest and tell us so we can keep an up-to-date record, because there aren't clinical studies in all herbal medications and infliximab, and it just gives us some evidence that should we think there's problems with interactions, we can alert the pharmaceutical company so they can feed back to us. So the most common side effects that we know that patients get with infliximab is some patients is mild nausea, vomiting, mild diarrhea, mild stomach pains. Lots of patients do report this runny nose or a stuffy nose or a cold-like feeling after they've had the infusion. And that's because it's a foreign protein, and the foreign protein is a bit like having an asthma. It just irritates the mucous membranes of the nose and therefore gives you that runny nose. If it becomes too much of a problem, then we can look at either changing your treatment or we can make recommendations to actually prevent it happening. And then we also know that patients report headaches. What we do know about infliximab is that we shouldn't be using it in the presence of infection, and we do need patients to be up and honest with us about signs of infection, in shortness, increasing in breathness, coughing up mucus, because that could be associated to TB. Any changes in lower leg swelling, especially ankle swelling, which we call edema, shortness of breath, because there is a potential theoretical risk that your heart struggles, sometimes not with the disease, but as we get older, and these drugs can cause a problem. So we want you to be honest if you think, I'm putting on more weight, I'm starting to see lower leg edema. Any changes in your bowel habits, you need to let us know. Any changes in skin reactions, like things like a butterfly rash on the nose, over the nose, because that could be a contributing side effect. Some of these start in the early start of the disease. If you've been on the drug for some time, they don't appear to be a problem. But patients, we do want us to, any time, just let us know if you're worried about any change in signs and symptoms. But when we definitely want people to let us know is should they have any allergic reactions that include hives, acute shortness of breath, swelling of the face and tongue, lips. Now, this normally would only occur in the first 3 infusions because it is a foreign protein. The body can build an allergic reaction to the drug, causing this allergic reaction, and we have to stop the infusion. Some people have gone home and then suddenly have these symptoms. They do need to seek medical opinion. If you get fevers, night sweats, weight loss and tiredness, once again, we're just worried a bit more about things like reactivation of a dormant TB. Any changes in the abdominal pain, you need to let us know. If you feel you're easily bruising, let us know. Now, the difference for patients on infliximab is your blood tests are always checked prior to your infusion. Some of the other patients who are doing injectable, it's important that they may be noticing things that actually because we're not seeing them at the time of their injections. When can't we use Infliximab? Should you be having any live vaccines, they're contraindicated. A history of cancer. Now, the cancer is likely to change in the near future, and we will advise you when that comes out. But it may be that actually you will be able to just stop your Infliximab treatment during your active treatment for a cancer, and then as soon as that's over and your oncologist has happened, you'll be able to restart your treatment. At the moment, you have to stop it, but there is likely to be a change in the next 18 months, and we'll keep you updated. Any evidence of an active TB, evidence of an active infection or high risk of infections. One of the things we do know, and this has been the hardest thing, is that people are perhaps not necessarily told us they've got an ingrown toenail that's infected, and then we give them infusion. That's not safe. We do need to know about any potential infection. It means we do have to delay your infusion, but the risk of actually having a complication associated to have been over-suppressed by this drug may make it more of a problem if you haven't told us. Any changes in neurological history, diseases, heart problems, and then pregnancy and breastfeeding. The guidelines have slightly changed, and I'll update you on that. So any signs of infection, you should stop your treatment, let us know, delay your infusion, whether it be a gastrointestinal infection, urinary infection, chest infection, you've had an episode of flu. It's important that you get over that, and then we restart your treatment 3 to 5 days afterwards. If you are on antibiotics, you need to stop the treatment, delay your infusions, and then wait 3 to 5 days after you've completed the course of antibiotics, and only restart the Infliximab if you've got no signs of infection and you're generally feeling better. There are some patients that we will still infuse, so there are some really life-threatening diseases where these drugs are used, what we call off-license. But once again, we closely monitor them. So there are some patients who are on lifelong antibiotics, and there are some patients who, because of their disease, that may, if we stop the treatment, they may actually be more unwell. Surgery, normally you have to stop the infusions 2 to 4 weeks before surgery and only restart once the wound is healed, there's no signs of infection, and you're not on antibiotics. You've always got the helpline to ask should you need that advice. Live vaccines, mostly are the ones, say, if you're travelling to third world countries like where you need yellow fever, typhoid, are live vaccines. But there are a whole host of them that are live vaccines, so you mustn't have them. That includes the shingles vaccine at the moment, although in the next 18 months, once again, that will change because that will move to a dead vaccine. We do want you to have the yearly flu vaccine. We did have a lady, unfortunately, who was on biologics, who a couple of years passed away. She'd had flu, she was on a biologic, and she hadn't had the flu vaccine, so at a young age we lost her. So it is important that patients do really take on board that the flu vaccine does help us prevent complications or prevent flu. Yes, lots of people have problems with the flu vaccine, but actually it's better probably to have a few weeks of feeling generally unwell than being life-threatening. And we do want patients to have this once in their lifetime pneumovax. If you're not sure if you've had the pneumovax, your GP should tell you if you've had it. There was a shortage of the drug for the last couple of years, but all our patients on Infliximab should have had a pneumovax at some point in their life. Come into contact with anyone with chickenpox, or you're worried about chickenpox, then do contact us on the helpline. We will be changing our process in that we will be screening for this in the future prior to starting treatments. But should you come into contact with chickenpox, or you feel you've developed chickenpox or shingles, you need to let us know. So we'll do a blood test and decide whether we need to treat you in different ways. Infliximab and pregnancy, we no longer have to stop this treatment before conception, and women can carry on within the first trimester. They do have to swap either at the second or third trimester of the pregnancy, and it's not compatible with breastfeeding. But the new thing for men, so you can now father children if you wish.
Thank you very much.
Without having to stop your treatment. Alcohol isn't a problem. The alcohol is more a problem with things such as methotrexate. But we do ask patients to let us know if they're drinking more than 14 units of alcohol a week, just because it may be why they're not doing as well on treatments or having other health problems associated to why their liver function tests are becoming abnormal. if people are struggling and they're worried about their alcohol, there's lots of information on the Portsmouth Health and Wellbeing sites and also Department about how people can access support. But once again, we want to try and keep you as long on the drug. So if you're having problems with methotrexate and alcohol and it's affecting your liver, it may mean that the Infliximab is not working as well if we have to keep stopping the methotrexate. Smoking, the reason we want our patients to stop smoking with these drugs is really, it may have been the cause of why they developed an inflammatory arthritis in the early stages. More research would also suggest that patients who are on biologics don't respond as well. Their disease seems to be more aggressive and their treatments don't seem to be as effective. So if they're people who want to stop smoking, we can put them in the right direction. We are happy for patients to do the e-cigarettes or the vaporizing at the moment, although there are health problems associated to that as well. We do know that biologics can cause fatigue, and that's because it is a foreign protein being injected into the body, which may make and contribute to why people get this fatigue. It's a bit like having ongoing flu sometimes. So we do want patients to let us know. There are things that we can do. We can review the medication. We can look and see if there's other reasons why they're developing the fatigue. Because there's a whole host. It could be the disease itself. It could be a medication. It could be anemia. It could be other health problems. It could be stress, poor sleep. Remember, when you've got inflammatory arthritis quickly, your body deconditions quite quickly, and therefore for any challenge you put upon the body may make it more difficult, and therefore patients do experience the fatigue, and then mood can be a problem as well. Sunburn, and going out, now we've got this nice new weather, we do want patients to remember they should be using a sunscreen. You may be more sun sensitive, and of course the risk of skin cancer is always slightly higher in patients than taking biologics. So we don't want our patients having to, or burning, because that then makes them more at risk of these basal cell carcinomas. But you should also be checking any spots, moles that are changing shape, colour, bleeding, then you need to let us know so we can get you off to see the dermatologists. If you are travelling abroad, you don't have to take the drug with you, but you will need to take your methotrexate maybe. Remember, we will give you a letter to take with you if you need to say you're on Infliximab, because these drugs may not be used in all countries that you may be visiting, and therefore they wouldn't necessarily have the information. So if you are travelling abroad, we can give you a travel letter, we can give you a copy of last blood tests, we can give you an information sheet that you can put in the bottom of your suitcase with your insurance. Always check your insurance as well, because sometimes they do have really small clauses, like if you've received a medical procedure in the previous 2 weeks, your insurance could be null and void. So always read the small print, because they could say, well, actually, you didn't declare that, therefore your insurance is null and void. We don't have a problem too much with patients forgetting to take their medication, because you once again have to come to the infusion unit. But we do find that people forget to tell us if they're not coming because they've got an infection and things like that. It's important to try and maintain and stop you having too many fluctuating doses, because it may be why you start to lose benefit with these drugs. Also, people who are intermittently forget to come for their appointments on time, they may find that the disease has incidental flares, which once again then may mean that the drug stops working or doesn't do its job we want it to do. And then we follow up escalating the drug treatments. But there is also a cost to the NHS for every time someone doesn't turn up for their infusion. In general, you have to have blood tests prior to each infusion. Some consultants may change that. It's up to each individual consultant to decide if they want to change your blood tests. In the early stages, if you're on other treatments, then we increase your frequency of medication. So if we add in a new medication, you may find that you have to go back to monthly or 2 weekly blood tests rather than the 8 weekly, but we will always tell you about that. How your blood tests are monitored, the samples are either sent, well, normally are sent to our pathology lab here. They process them and they get uploaded onto a number of hospital systems that both us and your GPs can see. If you're out of area, then those blood samples get sent by paper copy or email to the Biologics and Dawn team, who physically upload those to the system. If the blood tests are grossly abnormal, the pathology lab will ring us, and then we would normally ring you. But bear in mind, once again, if you've had the blood test today and you're due for your infusion tomorrow, we may just wait to see you till tomorrow. All the blood tests go into this system called Dawn, and Dawn looks for abnormal blood tests results. If they're normal, it just files them into a file to say they're safe. If they're abnormal or tending to a trend to abnormality, we get a red flag. The medical and nursing team review that on a daily basis. And once again, if there's any problems, we would ring you or write to you if we want to change your treatments or medications. If a blood test doesn't arrive, Dawn also alerts us, and then once again, the Dawn team would send you a text message saying you failed to have your blood test done. If you haven't had done it within a certain number of days, we send you a letter. And once again, if you have it again, haven't had it after a certain number of days, we write to you saying we're stopping your treatments, and we also send a copy to your GP. Don't worry if we do send you one of those letters and you have had your blood test done. There are a number of reasons why the blood tests don't get processed. So it could be mislabeled, wrong information, 4 points of contact of the information that needs to be to process a blood test sample is not there, illegible writing. Sometimes the sample bottles are out of date and someone's not realised, and therefore the chemical that reacts with the blood in the sample tube doesn't work, and therefore the sample can't be processed. If you have had a blood test done and you've had a text message or a letter, don't worry, just ring the helpline and say you've had the blood test done, or you can email us, and then we will just update our records. Sometimes Alex may not send that text message until the afternoon or evening, and you may have had that blood test in the morning. It's been uploaded onto the system. There are some patients experiencing blood test problems at the moment in our area. If you are experiencing problems, you need to let us know. In general, if you're on methotrexate in combination with Infliximab, you should be able to have your blood test done at your GP surgery or of any of the phlebotomy services run by Portsmouth hospitals. If you're only on methotrexate on its own, then you will now have to have your blood test purely at QA or Gosport, Petersfield or St Mary's. The services have been changed slightly, but hopefully you're on methotrexate as well, yeah? So that's not a problem for you. Remember, we've got the helpline. You can either telephone us if you're worried at all, or you can email us. If you do either, you need to make sure you give us your full name, date of birth. Sometimes we get patients ringing up and say, hello, it's Mr. Smith here, can you ring me back? And we've got no way of finding them on the system. The nurses download the helpline Monday to Friday, normally 4 times a day, and we will get back to you within 48 hours. Some days the nurses officially run the helpline between 9 and 5, but if they're in early on a certain day, they may start ringing patients at 8 o'clock in the morning. And we also, on some evenings, work up till 8 o'clock, so you could receive a call back up until 8 o'clock in the evening. That's predominantly Monday, Tuesday, and Thursdays. And over the weekend, although we don't advertise the helpline is open, we have nurses who are in, and if they haven't any inpatients to look after, they will continue to work on the helpline. If you're moving out of area, bear in mind you need to let us know quite quickly, because you will need to register with a new GP, and that GP now has to do a referral to another rheumatology department to take over your care, and that process can take some time. We officially cannot continue to provide your care once you've moved out of our area unless your GP has given us permission to do it, and it's to do with the NHS funding. Don't worry about that. Don't worry about that. So the wastage storage is really, once again, mostly with the subcutaneous injection, but we have had patients who have got into clinic or got into the infusion unit, that we've gone through the checklist and we've made the medication up, and then they said, oh, I forgot to tell you, I've got a infected grown toenail. Once that bag's is made up for you individually, we have to throw it away. So we just ask patients to be up and honest with us. Just tell you about biosimilars, because you've probably moved over to Inflectra, have you both? Yeah. So biosimilars are now in the rheumatology field. We've got 4 drugs that are biosimilars: the Remicade, Infliximab, Enbrel, etanercept, rituximab, Thera, and adalimumab, Humira. And Infliximab was the first group of our patients to move over. We were going with either Inflectra or Remsima, These are both manufactured by the same pharmaceutical company, and they're just named differently because they were licensed to two different pharma companies to be distributed. So they are actually the same drug, it's just they got different names because of who they were licensed to sell with. The biggest thing to remember is to be called Infliximab, it has to, the actual drug itself and the components of the drug have to look identical to the old Remicade brand of drug. They can't be any different. If they're any different, they can't be called Infliximab. The only difference and why they are slightly cheaper is that the biosimilar companies didn't have to identify the target cell and they didn't have to identify the characteristics of the drug and how it worked against those target cells. So they didn't have to do those phases. What they did have to do is they still had to do the preclinical data safety, they had to do the preclinical data studies, they had to look at comparable studies, they had to look at the risk and side effect profiles, and they had to do the same. So they had to do those bits, they just didn't have to do this bit. And that's why they were they are slightly more cheaper or cost effective. And we have to, in the NHS now, prescribe drugs against the clinically effective and cost effective. And so Inflector for us is the same, but it's slightly cost effective. The other thing is to be called, Infliximab has never been the same from day one to today. It has evolved over the years. So there's always been what we call a batch variation. The outer perimeters of what the drug does and looks like have stayed the same. And to be called Infliximab Remicade, they had to stay within those perimeters. But every time they do a new batch, there is a slight change in the drug. The biosimilar companies had to do the same. So they had the same perimeters as the originator, and they have to stay within those perimeters. But every time there's a new batch, they may slightly change. But we don't believe it causes a particular problem with patients. The European Medicines Agency have also licensed them using a number of reports. So this is the ones for biosimilars for Humira. On their webpage, they list all the drugs that have a European license and safety in the Europe and in the UK. We don't envisage being a problem with Brexit. That's a big concern for us because most of these drugs aren't manufactured in the UK, they're manufactured abroad. We have been reassured by all the pharmaceutical companies that should Brexit cause a problem, they have enough supply to see hospitals and patients through for a number of months until the Brexit concerns can be addressed. We have to prescribe biologics under the biosimilars under the British Society of Rheumatology and British Care Professionals in Rheumatology. And so there is a report about how we should use those drugs, and we've followed that in about how we've implemented it over the past 3 years. Just tell you what else is going on. One of the big things and what's changing in healthcare at the moment is we're trying to move from patients just turning up and saying, tell me, nurse, doctor, what I need to do to get better, to, in relation just to medication, to actually trying to engage patients, saying there are lots of things they can do in their general health and well-being and lifestyle choices that may actually prevent them being less disabled by their arthritis. So there's a lot more about these patients being a bit more activated and making choices for themselves and healthy lifestyle choices. So to do that, we've developed a whole host of programs. We're still doing the one-to-one personalised care plans. Hopefully you've got those. If you haven't got those folders, let us know and we can let you have them. We're still running our one-to-one supports through clinics and through the helpline. We continue to work with the different charities that support our patients. And then we've developed a whole host of programs that are there to support patients, keep them up to date with their arthritis and give them some tips to actually live healthier. And we've learned that once again from the diabetes and some of the other specialities that actually the investment in this really does prevent patients becoming disabled later on in life. So to that end, we have a No Time for Pain, which is about understanding pain in arthritis and how to manage it using both your medications effectively and also other techniques. If fatigue is a particular concern for you, we've got a Tired of Being Tired program, which is 7 weeks of looking at what causes fatigue, and then some tips and some self-management ways of managing fatigue through exercise, relaxation. We've got a flare roller coaster, which is looking at flare management. And then our newest one is Put Your Best Foot Forward, which is foot and ankle pain in inflammatory arthritis. So patients can self-refer to themselves through the emails, through our conference emails, or through our helpline. Everything we do is advertised on our webpage. Most of the things that's going on now or coming up is on the right-hand side, and most things that's about what's on an ongoing thing for the department is advertised on the left-hand side. All our education updates, so we will be doing, should there be new news about Infliximab that we need to tell our patients, we will offer both information on our webpage through email contact with our patients and also perhaps a medication update. And Dan's video from today in a few weeks will be online, so you can go back and revisit the talk if you wish. So we work with the charities. These are the ones we work closely with, and you can find other charities that we're working closely with through our webpage. They have lots of information. The National Rheumatoid Arthritis Society has a really good booklet on medicines in arthritis now, so that's really helpful for our patients. We are moving more to an email communication with our patients, so we ask our patients to sign up for the email communication. At the moment, we're not fully there, so we are still having to do partly a mail shot, but the hope is by early spring next year, we should be turning off mail shots and just doing an email communication and only sending paper copies to people who've asked for a paper copy to be sent. Other things we do advertise on the Trust Twitter webpage or Twitter program and also Facebook. And that's it, really. Thank you.